Today we will be discussing competency 1.13, that is the beta-adrenergic antagonists, or we also call them blockers. Beta-adrenergic receptor blockers, they mainly act on beta-1 and beta-2 receptors. They have minimal effect on beta-3 receptors. They are competitive antagonists and they are effective in treatment of various diseases like hypertension, ischemic heart disease, congestive heart failure, myocardial infarction, and certain arrhythmias. First of all, we will discuss the classification of beta blockers. The examples, only the examples are given along with them. Firstly, the non-selective beta blockers, that is, they don't have any selectivity either for beta 1 or beta 2, they act on both. The ones without intrinsic sympathomimetic activity, they are propranolol, timolol, sotalol, and the non-selective beta blockers with intrinsic sympathomimetic activity are like pindolol. Then we come to selective beta 1 blockers. They are like atenolol, metoprolol, acebutolol. And selective beta 2 blockers, they are butoxamine. First, we will discuss propranolol, which is the prototype drug for the non-selective beta blockers. They are one of the oldest clinically used beta blockers. They are available in both the oral preparations as plain and sustained release preparations are available. Now coming on to their pharmacological actions, firstly on the cardiovascular system. Propranolol, it tends to decrease the cardiac output. It has negative inotropic effect and negative chronotropic effect. That is, the cardiac contractility is depressed and the heart rate is also decreased. Directly they depress both the SA and AV activity, thus resulting in bradycardia, which is a dose-limiting effect of the drug. Cardiac output, work, and oxygen consumption, they are decreased by beta-1 receptors or the blockers. They are useful in angina. Therapeutically, they are effective in attenuating supraventricular cardiac arrhythmias, but they are not effective in ventricular arrhythmias. Their action on peripheral vasoconstriction, the beta blockers, propranolol, it prevents beta-2 mediated vasodilatation. So there is decrease in cardiac output leading to decrease in blood pressure, thus triggering the reflex peripheral vasoconstriction. And this reflex peripheral vasoconstriction would lead to reduced blood flow to the peripheral extremities. A gradual reduction of both systolic and diastolic blood pressure in hypertensive patients is also seen, but it may take a few weeks for the peak effects to occur. Beta blockers, they do not cause postural hypotension. Since alpha-1 receptors controlling the vascular resistance, it remains largely unaffected. Propranolol also causes bronchoconstriction, which is due to the beta-2 receptor blockade in lungs of the susceptible patients. In these patients, it causes bronchoconstriction, thereby precipitating the respiratory crisis in patients with COPD or asthma. Therefore, they are contraindicated in such patients. Propranolol, it tends to increase the sodium retention. This is caused by firstly reducing the reduced blood pressure. It causes decreased renal perfusion, which results in increase in sodium retention, and plasma volume is also increased. This is the compensatory response. It may elevate the blood pressure. Therefore, the beta blockers are often combined with diuretics to prevent sodium retention, especially when used for hypertension. Propranolol, it causes disturbances in metabolism. Firstly, we will discuss the glucose metabolism. It decreases the glycogenesis and also decreases the glucagon secretion. Therefore, propranolol administration in insulin-dependent diabetes mellitus patients, careful monitoring of blood glucose is very essential when propranolol is to be administered in IDDDM patients, as it can result in pronounced hypoglycemia. The beta blockers, they also attenuate the normal physiological response to hypoglycemia like tachycardia. Therefore, it tends to mask the signs and symptoms of hypoglycemia. So because of this reason, beta blockers, they are dangerous when administered to such patients. So they are contraindicated in patients of IDDM. Now coming to the therapeutic uses of beta blockers. Firstly, we will discuss hypertension. These drugs, they are mild antihypertensives and they do not significantly lower blood pressure in normotensive patients. The response, it takes time to develop over 1 to 3 weeks and is well sustained afterwards. So they are mainly used for maintenance therapies. They decrease the cardiac output and force of contraction. In addition, there is inhibition of release of renin from juxtaglomerular cells of kidney. In angina pectoris, beta blockers, they decrease the ventricular size and thus the wall tension is also decreased, thereby leading to decrease in cardiac oxygen demand. Beta blockers, they are effective in reducing the chest pain on exertion and the exercise tolerance is increased. So because of these reasons, they are useful in the chronic management of stable angina. In myocardial infarction, the propranolol, it has a protective effect on myocardium. If used immediately after myocardial infarction, it helps in reducing the infarct size by reducing the oxygen consumption. They also decrease the incidence of sudden death following myocardial infarction by preventing arrhythmia. Prophylactically, they decrease the subsequent mortality after myocardial infarction. In congestive heart failure, beta blockers, they improve the condition of such patients only in selected cases like dilated cardiac myopathy with sympathetic overactivity. They retard the production of congestive heart failure and they prolong the life of such patients. Long-term use prevents the remodeling in cases with increased sympathetic activity and they should not be used in patients with marked fluid retention. In glaucoma, Timolol is used topically. It is effective in diminishing the intraocular tension. In glaucoma, it is the second line drug of choice. The beta blockade reduces the aqueous humor secretion from ciliary epithelium by decreasing the cyclic AMP. This decrease in intraocular tension can be maintained for years. That is, Timolol is useful for chronic management of glaucoma. They do not affect the ability of the eye for the near vision and there is no change in the pupil size. In migraine, beta blockers, they tend to reduce the incidence, frequency, severity of migraine episodes. Propranolol is one of the most effective drugs for chronic prophylaxis of migraine, though it does have some fallbacks like weight gain and others. In hyperthyroidism, beta blockers, they blunt the widespread sympathetic stimulation that occurs in this condition, that is tachycardia, palpitation, tremors, nervousness. They blunt the sympathetic stimulation in hyperthyroidism. In addition, it blunts the peripheral conversion of T4 to T3 also. In thyroid storm, that is the acute condition, it is life-saving in protecting from additional production of cardiac arrhythmias. The arrhythmias, they are blunted. Other than these beta blockers, they can be used in Parkinsonian tremors, dissecting aortic aneurysm, and the anxiety disorders. Also, in anxiety disorders, it calms the patient over sympathetic stimulation that is blunted. Coming on to the adverse effects of beta blockers, bronchoconstriction we have already discussed. So because of this, it is contraindicated in patients of COPD or bronchial asthma. Arrhythmias, due to sudden stoppage of beta blockers which may be severe. It blunts arrhythmias, but it can produce arrhythmias when the beta blockers are suddenly stopped after administering them for years together. Because of this, because there is long-term use, it leads to upregulation of beta receptors. Because of this reason, Beta blockers should always be tapered off gradually over days, weeks. The beta blockers, they are avoided in diabetics. We have discussed it causes hypoglycemia, and the signs and symptoms of hypoglycemia, they are masked, which can be dangerous. Other adverse effects, there can be sexual impairment in males through alpha-adrenergic activation. Beta blockers, they do not affect ejaculation nor the internal bladder sphincter. The receptor selectivity is never 100%. So, how much a drug is blocking which receptors, the side effects can be according to that, and the actions also. The disturbance in metabolism, like glucose and lipid metabolism, they are disturbed. They cause bradycardia. We have studied the pharmacological action that it decreases the heart rate. Cold extremities can occur due to the peripheral vasoconstriction, which is beta 2 receptor action. Tiredness and reduced exercise capacity can also occur. The drug interactions, the drugs interfering with metabolism of propranolol, like cimetidine, furosemide, chlorpromazine, they may potentiate its antihypertensive action. The drugs which stimulate its metabolism will mitigate its effect, like phenytoin, barbiturate, rifampicin. So we have to be careful, or we can use alternate drugs when propranolol is given. Propranolol is given in an initial dose of 40 to 80 milligrams per day, and gradually it is increased to 320 milligrams per day. Stoppage should always be gradual. Otherwise, there can be rebound hypertension, worsening of angina, arrhythmias, and even sudden death can occur on sudden stoppage of beta blockers. So it has always to be tapered off slowly. Contraindications: bronchial asthma, insulin-dependent diabetes, partial and complete heart blocks. In these conditions, beta blockers are not to be used, especially propranolol. Coming on to Timolol and Nadolol, these drugs, they are more potent than propranolol. They do not have any intrinsic sympathomimetic activity or membrane stabilizing activity. Timolol, we have discussed, is second-line drug of choice for chronic open-angle glaucoma, and it is used topically. Nadolol, it has a very long duration of action with elimination half-life of 14 to 24 hours. Nadolol can be used in hypertension and angina. Now coming on to the blockers with partial agonistic activity like pindolol and acebutolol. These drugs, they weakly stimulate with beta 1 and beta 2 receptors with intrinsic sympathomimetic activity. They stimulate the beta receptors to which they are bound, yet they inhibit the stimulation of more potent endogenous catecholamines, that is adrenaline and noradrenaline. The result of this opposing actions is much diminished effect on heart rate and cardiac output with respect to beta blockers without ISA activity. They have minimal disturbance. They cause minimal disturbance of lipid and carbohydrate metabolism. Therapeutically, these drugs are used in hypertensive patients with moderate bradycardia, and they are also valuable in diabetic hypertensive patients. Now coming on to selective beta-1 blockers like atenolol, metoprolol, esmolol, acebutolol. They have been developed to eliminate the unwanted bronchoconstriction, that is beta-2 receptor activity of propranolol. They selectively act on beta-1 receptors and they antagonize them. So this antagonization is at doses 50 to 100 times less than those required to block beta-2 receptors. The pharmacologically, they act to lower the blood pressure in hypertensive patient, and they also cause increased exercise tolerance in patients of angina. Coming to second generation, metoprolol and atenolol, they do not have either ISA or membranic stabilizing activity. Therapeutically, they are used in hypertension, stable angina, initial treatment of acute myocardial infarction, and in patients of mild congestive heart failure. It is available both in the oral formulation and the IV formulation. The IV formulation of metoprolol tartrate is available. Atenolol, it doesn't have ISA or membrane stabilizing activity. Adequate response is seen in weeks. Thereby, it is preferable for maintenance therapies. Efficacious in combination with diuretics, atenolol can be used in elderly with isolated systolic hypertension. These drugs, they are contraindicated in patients of acute myocardial infarction with high heart rate less than 45, the heart block greater than first degree, systolic blood pressure less than 100 millimeters of mercury, and moderate to severe congestive heart failure. In all these conditions, these drugs, atenolol is contraindicated. Esmolol. Esmolol, it has a short duration of action, that is, it has elimination of half-life of just 10 minutes. Because of this reason, it is given intravenously if required during surgery or the diagnostic procedures. It has little effect on peripheral resistance, pulmonary function, or the carbohydrate metabolism. So, esmolol is used if required only during surgery or diagnostic procedures, and it is given by IV route of administration only. It has a short duration of action. Therapeutic uses of selective beta 1 blockers. They are used in hypertensive patients with impaired pulmonary function, diabetic hypertensive patients. The cold extremities, they are not seen with the use of beta 1 blockers as they don't have action against beta 2 receptors. Now coming on to third generation non-selective beta blockers, that is, they have some additional actions also. Labetalol, it has alpha and beta blocker effect. It blocks both the alpha and beta receptors. The reversible beta blocker with concurrent alpha 1 blocking action that causes peripheral vasoconstriction and decrease in blood pressure. Labetalol is useful in treating hypertensive patients in whom peripheral resistance is undesirable. They do not alter the serum lipid or blood glucose levels, especially in elderly or the black hypertensive patients. Labetalol is alternate to hydralazine in treatment of pregnancy-induced hypertension. So labetalol is one of the drugs of choice for the treatment of pregnancy-induced hypertension. Labetalol can cause orthostatic hypotension and dizziness, which is because of action on alpha 1 receptors. They're blockade. Now carvedilol. Carvedilol has some additional effects also. It blocks beta 1, beta 2 receptors and alpha 1 receptors. In addition, it has antioxidant effect, which contributes to the additional beneficial effects in congestive heart failure. It also has antiproliferative effects. It has membrane stabilizing activity and intrinsic sympathomimetic activity. It also produces vasoconstriction, does not increase the beta receptor density. It improves the ventricular function and also reduces the morbidity and mortality in patients of mild to severe congestive heart failure. Celiprolol, another drug, it is safe and effective drug in the treatment of hypertension and angina as it decreases the heart rate and blood pressure. It does not undergo the first pass metabolism and it is excreted by kidney. The selection of beta adrenergic blockers for individual patients is dependent upon especially their relative affinity for alpha, beta 1 and beta 2 receptors. The intrinsic sympathomimetic activity, membrane stabilizing activity of different drugs, differences in lipid solubility, capacity to induce the vasoconstriction, and at the end, the pharmacokinetic properties. So, the selection is based upon all these features. And lastly, you will go on to attempt the MCQs on the Google Forms for your attendance. Thank you.